Welcome back, everyone. Tom Walters here from Rehab Science. This will be, I think, I'll say that without certainty because who knows? I've got some others, but I think this will be our last lecture in biomechanics. This is sort of the last main lecture I would do. I had some others that once in a while I would add in, but this is sort of the last main lecture. And this lecture is kind of a fun one to me because it's more personal in that, being in Southern California, I spent a fair bit of time training at, with professors from USC, including Chris Powers, who does a lot of work on functional lower quarter biomechanics. I actually did a 6-month sort of fellowship at his facility in Los Angeles and looked at a lot of this. And so I think this information, is really interesting. A lot of it has to do with the hip and the glutes and how well the glutes control, how important they are in terms of controlling the kinetic chain, the lower quarter from the low back down. So, and then where this applies into injury and pain science, that's a whole kind of discussion I'll try to bring in as we go along. But, I think just some interesting concepts here. So basically we're going to look at the lower quarter kind of from the low back down. This is really an area I've spent most of my career studying the lower quarter, from low back pain to the hip influence on the knee. So again, this is just an area that I find to be fascinating, and I hope you guys enjoy it too. So let's take a look at some of the concepts here. So when we think about, just first off, when you think about analyzing someone's movement, and we think about the 3 planes of motion, we've got the side to side, our frontal plane motion, where we see abduction, adduction, those kind of movements. And then the transverse plane is the rotational plane, so we'd see internal and external rotation, medial lateral rotation, whichever terminology you prefer, things like that, pronation, supination, those kind of rotation type movements. When we think about the lower quarter, and we think about potential risk factors, when you look at an image like this, what do you think about this? Does it look like a movement pattern you might encourage with someone, or a movement pattern that if someone displayed you might want to try and change a little bit? And again, I say this sort of lightly because, obviously this is a movement pattern that in most cases, if someone had some pain or had a history of an injury and they displayed this, maybe they had an ACL tear and had a reconstruction, and we were getting them back to return to sport, and you saw this in a squat, or maybe you saw them jump and land like this. This is something that we probably would want to try and improve because we know it can put some stress on various structures, especially at the knee, which we'll spend a lot of time talking about. And ultimately, this is going to become a lot of hip-based training. The glute muscles, right, they control the femur, and the femur is the top half of the knee, and so there's a lot of movement that can go on there that we can strengthen and learn to control at the hip to help protect the knee. Okay, so if we're thinking about the transverse or the frontal plane, we in this picture would think about hip adduction, adduction, the knees are coming together. And it's hard to tell from here, we can't see the transverse plane really well, but there may be some hip internal rotation where the femurs are spinning in, and we often see those occurring together, hip adduction, internal rotation. And then if we think about a side view, this isn't all the way to the side, but we can kind of get an idea of the sagittal plane. If we look at this individual landing, maybe in image C and E, again, this might be a movement screen. Maybe we're doing a drop test, and we're looking at their movement tendencies. If we're thinking about the sagittal plane, well, then we'll talk about a knee bias strategy versus a hip bias strategy. And in this picture, she may be a little more towards that knee bias strategy, maybe more than we want. If we could encourage her to use more of a hip strategy, tap into her large hip extensor muscles, it may help to reduce the likelihood of developing pain, things like, patellar tendinopathy, patellofemoral pain. Those are going to be some big ones on the anterior knee. These knee bias strategies, the knees travel past the toes, can in some people lead to different pain issues. So a way of combating that may be changing the person's biomechanics. You can really see as she lands here how the knees travel past the toes. You can see the large degree of dorsiflexion that's required because of that anterior knee translation. So if we could encourage a hip strategy, which we'll talk about those components in a little bit, maybe that would help improve performance and decrease pain. And I realize some of these strategies are really just things that you work on in training. They won't perfectly transfer to sport, because in sport you've got to do things dynamically, reactively. You don't have as much time to land perfectly. But the thought is that maybe practicing them in training, some of that will carry over and help reduce injury risk. We definitely have studies showing that coaches who implement warm-ups that target the hip can, for instance, when they track athletes over a season, so they did this in soccer players, that ACL tear rates drop considerably when the standard warm-up is changed to a hip-based warm-up. So again, maybe the thought there is that we activate and strengthen the hip muscles. That helps us control the knee. We have less injuries at the knee. It's just, it's one idea. So what could better form look like? Here's a video I took at a clinic that I used to cone, and this will be a sagittal view. This individual is a volleyball player. She's going to land on the force plate here, and we'll see the ground reaction force vector as she lands. But really just pay attention to her form, thinking about those things I just mentioned, anterior knee translation, hip strategy, and just kind of look at her form as compared to the girl we saw in the last series of images. So as she lands, she pretends to hit the ball and then lands. So you can see, right, there's a better looking hip strategy. And most of you would be familiar with this. Is what we kind of try to do when we do back squats. When we squat and things, you try to stick the butt out and back like you're sitting in a chair. And we actually have seen too that leaning the trunk like she's doing can help encourage glute or hip extensor activation and decrease activation of the quads, which if you have somebody who has a symptomatic knee, say patellofemoral pain, that trunk lean can help take stress off of the knee and tap into the glutes a little more. So this is a cool video showing the sagittal view and what a good hip strategy would look like. And again, she might not be able to land like that every time in sport. It just might not be realistic. But maybe if it's done in training and some of it can carry over, that may help reduce pain and symptoms and ultimately improve performance. Okay, so just a quick video of what a hip strategy looks like from the sagittal view. So just talk briefly here about Newton's laws of motion, the second and third laws. So the second law of motion, just to refresh your memory, is force equals mass times acceleration. I talked about this in the second lecture on kinetics, but when we think about analyzing humans and we think about this equation, mass isn't going to change a lot, right? The person is just the person unless we load them in some way. If you give them weights or something, obviously then the mass will change. But if we think about an athlete jumping and landing, their mass is pretty much staying the same. What's going to vary is acceleration, and that's going to change force, right? So force equals mass times acceleration. If acceleration goes up, then the force on their body is going to go up. And this is why if we think about these movement tendencies, maybe the knees collapsing into adduction, internal rotation, the injury risk is higher if the person's sprinting and changing direction or landing from a jump. Those are the two big ones. If you're just doing squats, the injury risk is not as high because the force isn't as high. You're in a squat, the person's moving slowly, so acceleration is much lower. And of course, it's their same mass. If they have weight on their system, they're doing a barbell back squat, then of course force will go up. But the acceleration, that change of direction, and that stress that's placed on the tissue tends to be more associated with things like ACL tears, things like that. If you're looking at pain, patellofemoral pain, IT band syndrome, then slow movements can also be associated. But most of the time it's going to be situations where there's a big change in acceleration. The person's decelerating, usually they're decelerating their body, and that creates larger force on the tissues. And then Newton's third law of motion says there's equal and opposite reaction force from the ground back on the body, which is what we just saw in that video I showed of the volleyball player. That green arrow is the ground reaction force. So when she hit the ground, there's an equal and opposite force from the ground back up towards her body. And we will be able to look at the arrow, that vector that comes off the ground, and we'll do this in a second. We'll look at where it passes through the body, and how that'll affect different muscles. So this is an example here. This person's pushing into the ground, driving this driving action force into the ground to propel themselves, and there would be an equal and opposite force coming back up from the ground. So the question we really ask is, can the subject appropriately transfer this ground reaction force, which will be abbreviated as GRF? So can they transfer it appropriately? And this is where in a second we'll look at the vector line where it runs their body. That'll give us an idea. I mean, you can kind of get an idea when you look at someone. If they land from a jump or are changing direction, their body's sort of collapsing. I mean, we all kind of know what good form looks like, and so if somebody's outside that, maybe they won't get injured, but it probably doesn't hurt to try and correct some of those things. Okay, so ground reaction force transfer. How do we define appropriate force transfer? So we're going to look at shock absorption. Within shock absorption, their movement strategy, joint excursion, how much of their joint excursion is, what range of motion are their joints moving through. Movement strategy is really going to be thinking about hip versus knee strategy in this lecture. And then we're going to talk about the active subsystem, which maybe you remember from previous lectures, the joint stability lecture. The active subsystem is really the neuromuscular side of our body. It's the area we have voluntary control over, so we can actively engage those structures through our nervous system. We can contract muscles, pull on tendons, and move our joints, versus things like ligaments, cartilage, joint capsule. Those are passive subsystem, bone. We can't really control them directly. And then we'll talk about dynamic stability. So we will go through each of these things as we move forward from here, but these will help us define what is appropriate force transfer, all of these components. So just a little look at what we're going to look at here. So in terms of shock absorption, we've got our passive shock absorbers, again, bone, cartilage, meniscus, labrum, ligament. You know, meniscus, intervertebral discs in our spine are shock absorbers. So really, you know, cartilage, meniscus, bone, intervertebral discs, they are passive shock absorbers. They're very important in absorbing shock, but we can't create a signal to contract our meniscus. It'd be kind of cool if we could, but we can't do that. So those, in terms of shock absorption, those are our passive shock absorbers. They're important, but we don't want to rely on them. Relying on them would likely be associated with greater injuries. So some in the knee, for instance, we talk about people who have a ligament strategy. So there are some people who are not very good at using their muscles to absorb shock, and they land with a stiffer landing. Stiff landings are more associated with stress on the meniscus, bone, cartilage, ligament. So that movement strategy, a ligament dominant strategy, is going to be associated with more with injuries. So we want to use our active shock absorbers, which are our muscles and tendons. And primarily, this is going to be through eccentric muscle contractions, where the muscle's contracting and getting longer. If you think about when you land from a jump, as you land and absorb shock, your knee is going to bend, your hip is going to bend, which as your knee bends, it's not your hamstrings contracting, it's your quads contracting but getting longer. They're acting like a brake on a car. They're slowing that movement down. Same thing with your glutes. When you land and your hip is flexing, it's not your hip flexors contracting, it's your hip extensors contracting eccentrically. So they're squeezing, but they're getting longer to slow the movement down. So that's going to be that type of a movement dominant or a muscle dominant strategy is what we're going to want to train people to do better, particularly if they land really stiff. Sometimes in the clinic, we'll tell people to try and land like a ninja. If you tell people that, they often will use their muscles more because they try to land without making a lot of noise and land softly. So we would do this a lot on the force plate. If somebody was landing really hard, we'd tell them to try and land like a ninja, and usually that would instantly make them use their muscles better. Okay, we look at movement strategy. So we got hip versus knee strategy, which I mentioned before. So we want to know, when we just look at them, first question, does the subject use their hip or their knee more to absorb ground reaction force? Okay, so just right away when you look at them, just try to figure out, are they using their hip more or their knee more? And when we think about this, the quads are super strong, right? The quads are going to play a big part in this, but they're going to be more associated with a knee dominant strategy. The glutes have such a large cross-sectional area and can generate so much force. We definitely want to include them in the picture. So if you see somebody who's landing in this sort of knee dominant strategy, it'd probably be helpful to teach them how to use their hip musculature a little more. And essentially that's working on kind of that hip squatting, hip dominant kind of pattern, teaching them to land like that. So again, as I mentioned, knee extensors are important, but we really want to try and focus on the hip. And this is really based on this research of showing that if we can get people to use their hip more, knee injuries tend to go down. So here's a hip strategy versus a knee strategy, again looking at this ground reaction force vector. So this person jumped and is landing, and we've got the knee strategy here, which tends to include these characteristics. The trunk is more upright, the knees tend to translate over the feet, and the ground reaction force vector will be closer to the hip and farther from the knee, which will create this larger quadriceps contraction, more stress on the knee, less glute activity. Whereas the hip strategy, the trunk is forward more, the hips go back, knees stay over the top of the feet a bit more, and what we see here is that the vector is closer to the knee and farther from the hip. The farther this line is from a joint means we will see more muscle activity in that joint. So this vector here is acting to create hip flexion. Imagine it pulling on the femur right here, which means the hip extensors have to work. So the farther this is in front of this joint axis, we'll have this larger hip flexor moment, which means the hip extensors will contract to counteract that. In this situation, we're farther from the knee. This is a knee flexion moment, which means the knee extensors will contract to counteract it. So just looking kind of that difference here when I talk about hip versus knee strategy, this is a picture you can imagine. So we want to encourage people, if they're landing like this, to teach them to kind of sit back, lean forward, use their glutes a little better. And if you see really good jumpers, they often do this, right? This kind of looks like the takeoff from a jump. If you look at someone who's skilled in jumping, their arms will kind of swing, they'll get that counter movement, they sit back and really load up their glutes. So characteristics of the knee dominant strategy, it tends to be stiffer landing. They don't have the same ability to move through a large range of motion in their joints. Most of it is coming through knee flexion, so they're landing, if you look at them from the sagittal plane, most of the movement is coming from knee flexion. And because they end up running out of room, usually what happens is their ankle dorsiflexion will be a limiting factor, and we'll see more compensations into the frontal and transverse plane, so you'll often see their knees kind of come together as they run out of space to move in the sagittal plane. So as their ankle dorsiflexion is maximized, they'll look for somewhere else to get movement, and so you'll see their knees often, most of the time, collapse inwardly. And we also see decreased trunk flexion, like on the last image. And again, this one tends to be more associated with injury risk. Not for everybody, but if it's one of those ones that because of the stiffer landing, more stress on the passive subsystem, we see more pain and injuries here. The hip dominant is going to be sort of the opposite in a lot of ways. We'll have a softer landing. Deceleration is primarily through the sagittal plane in the hip. It's hip and knee flexion. It's not like we're taking away the knee flexion. Obviously the knee is still going to bend, but we're going to get a bunch more movement at the hip. We see the trunk is flexed, so they're leaning forward. And again, softer landing, more control through the active subsystem, which is designed to absorb shock in that way, and we see the injury risk, especially on passive tissues like meniscus and ACL ligaments and things go down. So again, just thinking about all those characteristics, here's that picture again. So you can go back and forth between the last slide and this one and just kind of compare and look at these pictures if any of those things don't make sense. When we talk about the hip strategy, there's going to be three big important factors. If you're thinking about helping people learn this strategy better, these are the things you want to zone in on. So one, hip flexion. And we're going to look at this idea of lumbopelvic dissociation. So normal lumbopelvic rhythm, when our hip moves into flexion, our pelvis rotates into posterior pelvic tilt, and then we get lumbar flexion. That's the normal lumbopelvic rhythm. So if we want to create lumbopelvic dissociation, we want to teach the person to flex their hip while keeping their lumbar spine relatively extended. like people would learn in a squat, right? When you look at people squat, if you're trying to keep their spine in neutral, as their hip flexes, they would try to keep their low back arched or extended to prevent it from rounding. So the same kind of idea here. We want to allow the hip to flex while keeping the low back relatively straight. Trunk flexion. So even though the low back will be kept straight, it'll be like a hip hinge, right? Think about somebody who's deadlifting. They are flexing at their hip while keeping their spine relatively straight. Now the spine doesn't stay totally extended. We have studies showing that, but you're working towards keeping an extension. So the hip is flexing, and the trunk is flexing. And then we're going to look at knee alignment relative to toes, and with the hip strategy, mainly it's going to be that the knees stay sort of in line with the foot. They're not going to translate past the toes. Again, this is a thing, sometimes people see this and they think that knees going past toes is bad. That's not always the case. There are times when we would do that. There are certain conditions, even with something like patellar tendinopathy, if we really want to load the patellar tendon in the quads, we'll want to encourage people with exercises where the knee does go past the toes at the appropriate stage of rehab. But in something like landing, changing direction, things like that, it often, because those are such high forces on the tissue, again, encouraging this hip strategy and knee sort of behind the toe will just help unload the knee a little bit, shift more of the force towards the glutes and the hip, and help kind of protect the knee. So there are times where it's totally fine for your knees to go past the toes. So anyways, sorry. Excuse me. Okay, so those are the big three for the hip strategy. For hip flexion, we want to see this hip flexion in the sagittal plane, obviously, because it helps to absorb ground reaction force appropriately. So when we asked that question before, what is appropriate, how do we define appropriate ground reaction force absorption? This is one characteristic, looking at sagittal plane flexion at the hip and using the glutes, the hip extensors, to absorb, using them, along with the quads and knee flexion to absorb force. This is going to be controlled primarily by gluteus maximus. Gluteus medius, minimus will be involved too, and this is where a lot of this research from USC comes from. But both motor control and strength, there are a lot of people you'll meet that actually have really strong glutes, but they display these movement tendencies, and there's probably more of a motor control issue. They may have just not learned how to use their body in a certain way. But if you strength test them, they're actually pretty strong. So it's another one of those examples where just being strong doesn't necessarily mean that you'll move with good form. So we've got to combine motor control, and we want to have that strength foundation, but we want to teach people how to move with good form. Okay, so those are looking at hip flexion, and gluteus maximus we'll look at again here in a second and explain a little more why it's so important. Trunk flexion. So as I mentioned before, we have some research showing that when we flex our trunk, because of how that changes our center of mass, it encourages activity in the glutes, our hip extensors, and it decreases activity in the quads or the knee extensor. So it's a great thing to use even in people who are just doing they might just be doing regular exercises, and if they say their knee hurts during it, you can help them learn to use more trunk flexion, and that will often reduce knee pain, especially things like patellofemoral pain, patellar tendinopathy, anterior knee pain types of issues. If you can encourage a little bit of trunk flexion, it can help tap into their glutes, unload their knee a little bit, and they might be able to do the exercise without so much pain. So actually they've shown that when you lean the trunk, there's 28% less quadriceps activation in the trunk. I don't have the exact angle that they had people lean in this study, but just know, I think in an application standpoint, that leaning the trunk can help reduce quadriceps activity, which can help reduce stress on the knee, especially the anterior knee. And like I said before, flexing the trunk helps to encourage activity in the hip extensors, and especially things like gluteus maximus because of its huge hip extensor role. So when we look at the knee alignment issue in the sagittal plane, knees going anteriorly past the toes is more associated with a knee dominant strategy. We've probably all seen this if we've worked with clients, whether in rehab or training. You get somebody who's never learned to squat. Often if you ask them to, their first idea is just to let their knees go past their toes, and just their trunk is very upright and they just kind of go straight up and down, and they don't know how to sit back and perform sort of a better squat position. So that knee dominant strategy is the same thing. You'll see people, sometimes athletes who haven't been trained in this and how to land appropriately, you'll see them land with their knees going way forward. You'll see them absorbing a lot of the shock at their knee and just not using their hip well. Again, decreased activation of the gluteals. This is going to mainly come from their quads. And because it's coming from their quads, it's going to really load the anterior knee. And in young athletes, you might also think about Osgood-Schlatter's. Osgood-Schlatter's causes a lot of anterior knee pain in athletes who are involved in sports that are highly quad dominant, like volleyball, basketball, track and field, gymnastics. So they're using their quads a ton. In those activities, it just goes along with the sport. But if they have a problem like that, maybe in their training, you can help teach them a hip strategy so that at some point they're taking some stress off the anterior knee, and maybe that helps them get through the season, because some of these people have so much pain they just can't perform. So if you can help them learn a strategy that reduces symptoms, maybe they can keep going. Okay, dynamic stability was from a few many slides ago. We talked about some of these things we would look at. So dynamic stability is the next one here. And this is really, this has been a while now, probably over the last 15 years. There's been this transition in the research from looking at the foot and its influence on the kinetic chain. For sure, that's still important. You still want to look at their foot, consider the whole picture. But there's been more of a shift towards the hip, because the hip, especially when we look at the knee, can have more of an influence on the knee. That the hip can move through a wide range of motion, and the femur is part of the hip and it's part of the knee. If we look at the foot only moves, it can only influence the knee. It influences the knee less because it doesn't have a direct connection to the knee. So the foot can pronate and supinate. That then has to transfer to the tibia and affect the tibia, which would then go on to affect the knee. So the foot definitely plays a role and should be something to consider. But if somebody had a foot issue and a hip issue, you'd probably get more bang for your buck by looking at the hip. So a lot of this comes from knee pain studies. This transition towards the hip, again, a lot of it, different places in the world, but Southern California was a big one. Looking at people, especially with patellofemoral pain, kneecap type pain, they found that when they did squats, that if the person, and a lot of these people, they weren't controlling their femur well through the glute muscles, and that was causing, things like internal rotation, adduction of the femur, and that would change the orientation of the kneecap on the femur. And this was sort of new research and thinking, well, maybe this is one of the contributing factors to patellofemoral pain. So in some ways, some of this was found by accident. In some of these imaging studies, it was discovered that, how much of a role it played here. So the hip is a triaxial joint, right? It can move in all three planes of motion, sagittal, frontal, transverse planes. It has, because of that, it's because it's the ball and socket, it has a greater mobility, it has more mobility, and often joints, the shoulder is even more true of this. Another ball and socket, it's even less stable than the hip. Joints that are more mobile have less stability, and if the neuromuscular system, if the passive subsystem, the active subsystem, if they're not controlling the joint well, then the injury risk, may go up. So think about the shoulder, you see way more dislocations in the shoulder than the hip, right? The hip is just naturally more stable. To a really mobile joint like the shoulder, that injury risk maybe is a little higher if the person can't control it well. But the hip has the same kind of ideas. We've got, in the hip, the increase in mobility often ends up hurting the knee. So that force ends up transferring to the knee, and the hip structures can sort of tolerate the force, but the knee, it's a condyloid joint. It moves to flexion extension, it has some rotation, but in a way it's kind of just like a hinge joint, and it cannot, if you aren't controlling the hip well, that force can move into the knee, and the knee doesn't have the same mobility as the hip, so it can be damaging to knee structures if the hip isn't controlled well. Same for the foot. You want to consider the foot, but in a lot of people, the hip has a greater influence. So when we look at hip joint control, again, we're talking about, remember the hip, it's a ball and socket, so you've got the acetabulum as the socket, and then the femoral head, and then the femur comes down, and it forms the top articulation of the knee joint, right? The knee is the femur and the tibia coming together. So femur control is a huge one. Again, these were found in studies where they were imaging people, they were having them do squats, and they were looking at how the femur was moving. And in terms of compensations that we tend to be concerned about, they mainly are frontal and transverse plane compensations, and specifically it's hip adduction, internal rotation. So situations where the knee is collapsing towards the other knee. So when that happens, in some people it's mainly adduction, in some people it's mainly internal rotation. A lot of people, you kind of see a little bit of both. So the femur will kind of move in, and it might rotate in as well. And if you see those things, those are the compensations that are more associated with injury, especially to the knee. But you do see some people get hip pain too. Like you might see bursitis on the outside of the hip, or maybe IT band type syndromes on the outside of the leg associated with this type of movement pattern. So when we look at, here's a, again, if you saw somebody land from a jump like this, you see you see foot and hip influences, right? And it kind of sort of becomes, chicken or the egg, which one's driving which. But you can see, especially here, a lot of foot pronation, both knees collapsing inwardly. For sure, hip adduction, maybe some internal rotation. If we had a 3D camera system, we could see the transverse plane. But this kind of movement pattern can be associated with all kinds of issues: stress on the inside of the knee, on the outside of the knee, IT band syndrome, patellofemoral pain, hip impingement, tibialis posterior tendinopathy, ACL tears. Some people even back pain and things. So it just, right, if you saw that, you would think that's probably not an ideal way to absorb force. So this, ultimately probably speaks to an inability to stabilize in the sagittal plane. The person's not using, if we could look from the side view, right, we can't see the sagittal plane right here, but we can probably guess that, there's probably not a super great hip strategy. So if we could teach that person to tap into that hip strategy better, sit back a little more, maybe that would clean up some of this movement pattern. And so usually people they can't stabilize well on the sagittal plane, they don't have the strength or the control, and that leads to these kind of compensations in the frontal and transverse planes. Dynamic Q angle is something that you've probably heard the term Q angle. This used to be measured, we have an Q angle, there's sort of an average range. Guys and girls are a little bit different. There's a static Q angle, which is just when you're laying there, and it looks at this angle from the tibial tuberosity straight up through the kneecap versus coming from the kneecap up to the ASIS, and how much of a difference is there. So if you imagine, dynamic Q angle is the Q angle when you're actually moving, and that's been a better predictor of injury than a static Q angle. So if you think about this individual, if you drew a line from the tibial tuberosity up through the middle of the kneecap, that would kind of point up this direction. And then if you drew a line like this one here from the middle of the patella up to the ASIS, there would be a huge angle right here between these two lines. So that is a large Q angle. The larger that Q angle gets, the greater the injury risk. Where you imagine if she landed straight and her knee was not collapsing in like this line wouldn't shoot off over here so far. It might shoot off kind of straight up, and then the angle between these two would be much smaller. Injury risk would go down. So that's how dynamic Q angle is used, that type of measurement. Again, dynamic Q angle is a much better predictor of injury than, if you just have somebody lay on the table and measure a Q angle statically without moving, it's not actually that helpful. So again, injury risk increases as dynamic Q angle increases. Probably not surprising. I think all of us would look at this picture and think that's probably not ideal. So again, gluteus maximus, a huge muscle. It's so important for hip strategy, mainly because we think about the hip as a triaxial joint. The cool thing about gluteus maximus is it can move our hip in all three planes of motion. Most people think of it as an extensor, but it also has an abductor role and an external rotator role. So we've got our sagittal plane, our frontal plane, and our transverse plane. So gluteus maximus, because of these different fiber directions, is just not only has it got a big cross-sectional area and it can generate a lot of force, it can also create movement all three planes, which means, it's going to help us absorb force in the sagittal plane. Remember we talked about the compensations we see that we want to try and limit: hip adduction and internal rotation. Well, this muscle is an abductor and external rotator, so it can pull us out of hip adduction and pull us out of hip internal rotation. So encouraging gluteus maximus activity can help limit some of these tendencies that might increase injury risk. So really important muscle, obviously, in this whole lecture. So when we look at, think about gluteus maximus, we see someone land like this. Again, some of this is just motor control. It might be a mirror. You put a mirror in front of them and you tell them to land, kind of cue them how you want them to land. But you can imagine how gluteus maximus could help with this. It's helping absorb force in the sagittal plane. It's keeping the knee out into more abduction and keeping it rotated out more into external rotation and helping to limit some of these things. Now, it's not like you can just tell somebody turn on your gluteus maximus and this will happen, right? That's not really realistic. But maybe you have some exercises, which I'll show some in a second, that help to strengthen gluteus maximus. You might even think of things like fire hydrants. Fire hydrants have been studied a lot for this. They really are a great one for encouraging activity in the motor cortex of gluteus maximus. So that's one of my favorite ones. But there's lots of different band options and things you can do. I mean, even just doing things like single leg squats and working on your form and position, maybe using a mirror in the beginning, can help to strengthen gluteus maximus. So again, but for a lot of people, they might already be strong. It might just be teaching them how to move differently, just giving them some feedback and helping in that motor learning process. Okay, pelvis and trunk obviously are also important. We've talked about the trunk already a bit, but when we get into this dynamic stability topic, we want to look at the pelvis, and we'll look at there's one area of the pelvis that we look at quite a bit when we're analyzing movement. And we see compensations here. When we see compensations in the trunk and pelvis, it tends to be mainly in the frontal plane. The person might lean their trunk, or we'll see pelvic drop. So we'll look at that in a second here. And this is mostly associated with hip abductor issues. I do a post on this usually every year on the importance of gluteus medius and its role in keeping the pelvis level, which also, if you keep the pelvis level, usually then the spine won't lean. So I'll show an image here in a second, but if you see these kind of trunk or pelvic compensations, again, you want to think back. One of them, maybe the first places you look is at their glutes, and especially their abductors, gluteus medius, gluteus minimus, and obviously gluteus maximus too. So you might see pelvic drop or trunk lean, and these are some types of compensations you can see. So we've got A, which is sort of the pelvis is level across the top here, relatively level. This would point towards pretty good control. So GM is standing for gluteus medius here, but gluteus maximus, gluteus minimus, it's all three of them really. But they're not leaning, if you imagine their trunk here, they're not leaning too much, the pelvis is relatively level. And then we can have situations like this, where we have a pelvic drop. We call it a contralateral pelvic drop, CPD, because it's the opposite side of the leg they're landing on. So they land on their right leg, and they get a left pelvic drop, so that's a contralateral pelvic drop. You see that in a lot of people, and this is controlled by the abductors over here. Gluteus medius on the right hand side right here, its function is to keep the pelvis level when we're standing on one leg. So that abductor should pull this side of the pelvis up. So that's where strengthening neuromuscular control exercises could help if we see a contralateral pelvic drop. So this is called an uncompensated. The person's not compensating, they're just sort of falling, and the pelvis is falling, they're just not controlling it. Then we have some people who have a compensated situation where their leg collapses in, and instead of the pelvis falling, they kind of pull it back up, and they try to do this center of mass. COM stands for center of mass. So they try to shift their center of mass and lean their trunk back over their leg to kind of straighten their body out. So you can see kind of both situations. This person, their pelvis will fall and they'll kind of be leaning away from their leg. This person, they'll kind of lift the opposite side of the pelvis and they'll lean back over the top of their leg. But in either case, you'll see their trunk is leaning and their pelvis is kind of shifting either up or down. So that you're kind of looking for, is their pelvis level? Are they leaning? And this can give you some idea of just their dynamic stability and how well they're using their hip muscles to control their pelvis and spine. So these kind of compensations in the frontal and transverse plane, again, we just keep coming back to the frontal and transverse plane. We want to use the sagittal plane primarily with that hip strategy, and if we do that, we'll see less of these frontal and transverse plane compensations, whether it's the trunk leaning, the pelvis dropping or lifting, or the femur moving into adduction, internal rotation. Those are kind of all the big ones. And maybe at the bottom, right, foot pronation, things like that. So these are associated with ACL tears. We see these in when athletes land from a jump or they're running and cutting, like in soccer. Patellofemoral joint pain syndrome, again, pain behind the kneecap. This is kind of where all this research started, was in people with patellofemoral pain. Femoral acetabular impingement, so pain kind of in the groin or front side of the hip when going down into squats. If people move down that position and their hip moves into internal rotation and adduction, it can cause more hip impingement. So this is why a lot of people who squat, they feel better with things like a sumo squat because it keeps you abducted and externally rotated. IT band syndrome, when the knee collapses in, it applies stress to the lateral side or the outside of the knee. So IT band syndrome is also associated with these kind of compensations. Hip bursitis on the greater trochanter, so trochanteric bursitis can be associated with this. And then on the lower leg, we can see things like arch pain, tibialis posterior tendinopathy, plantar fasciitis. So that collapsing, the leg collapsing inwardly. Remember we saw the picture of the girl where she showed all that pronation? That sort of movement pattern applies stress to the medial lower leg and can predispose someone to issues down there as well. So just all these things throughout the kinetic chain. And I didn't put low back pain in here, but you see that in some people. So this whole lower quarter, low back, hip, knee, ankle, and foot, all kinds of potential issues that could occur with people when they're, when you see these types of movement patterns where, we get back to that hip versus knee dominant strategy, and especially things where the leg is collapsing inwardly toward the other leg. So that here are just a couple of intervention strategies. So these are just a couple of ideas, but if we've got someone who is showing this inward collapse of their knee, we can use bands and things to help encourage motor learning, build strength, and have them, these can be functional in that we can pick because usually this is happening in standing. So if we can pick a standing position where these movement tendencies might happen naturally and then add an exercise, it can be useful. So here's one encouraging some hip abduction. So the band wants to pull the knee into adduction. This person has to use their glutes. Imagine gluteus medius, gluteus maximus, minimus up here, having to pull the femur into abduction out into the band because the band wants to pull the knee in. So those muscles have to work to keep the leg in this neutral alignment, keep it over the foot. So this can be a good way to teach the person's brain and nervous system how to tap into those muscles so the knee doesn't just collapse in towards the other one. Okay, so that's more frontal plane, abduction. Here's one that's a little more complicated but can address the transverse plane and the internal rotation. So this band is going to go on and it's going to do this wrapping pattern. So it wraps around the femur. So she's wrapping it in a way that would create internal rotation. So it wants to rotate the leg in. And so that means that her gluteus maximus and other external rotators are going to have to spin the leg out. So the band wants to pull it in. Now she's got to use her muscles to try and pull it out. So kind of a cool one. A little bit complicated to set up. Might take a few times to practice to get it right. But can you imagine that band wants to rotate the femur in? So she's going to use her external rotators to fight against that and rotate the femur back out. So kind of a cool one. It reminds me I need to use this one more. I forget about it. So, all right, you guys. Well, that is the end of this lecture. So I hope this is helpful, kind of a cool area, one that I like to look at. If you work with athletes, it can be a useful, some useful strategies. Even people who aren't athletes who are just looking to learn, maybe they've got knee pain, with things like squatting or lunging, you can implement some of these things. Maybe you can teach them to lean their trunk a bit more, or use more of a hip strategy to help reduce those symptoms. And then obviously in the athletes, maybe getting them to tap into their hip a little more can help reduce knee injury risk. So, all right, well, I hope you found this helpful, and I will see you all later. Bye.